Hi everyone, my name is Katie Coffey, and I'm going to be talking to you today about my DNP Scholarly project, which was a quality improvement project focusing on anaphylaxis in the outpatient setting. So, taking a look at my committee, the committee chair was Dr. Boniface Stegman, and my community member was Dr. Alan Grady, who is one of our radiologists and also the medical director of our site. The background and significance. So I currently work in a small outpatient imaging center, and this type of facility also often has very limited resources. They don't have staff that are trained for emergency situations, and often these emergency situations do happen. So we give iodinated contrast to patients that are having MRIs and CAT scans. And after getting this medication, patients are at risk for having a reaction to this type of medication, specifically anaphylactic reactions. So, anaphylaxis is a very severe life-threatening event. It is the most rapid and severe immediate hypersensitivity reaction that someone can have. The symptoms often include contraction of the bronchial smooth muscle and laryngeal edema, which can make it very hard to breathe. They often will have swelling in their mouth and their tongue. They can have swelling in their airway, and they're just going to feel like they're having a difficult time breathing, a difficult time swallowing. They may feel some numbness or tingling or itching in their mouth or their throat. And to add to that, it also can cause vascular collapse and a decrease in their blood pressure. So systemically, it can lead to shock as well as death. So 2% of people in the United States will experience anaphylaxis at some point during their life statistically. But due to the nature of the type of medication that we're administering with this contrast dye, it's more prevalent. And unfortunately, the prevalence is also increasing as time goes on, which is also bad news. This project was designed to better prepare the staff in these settings to care for these types of emergency patients and improve the patient safety when these emergent situations are happening. So, a review of the literature. So, part of this project involved changing our protocol, which prior to this was to administer epinephrine intravenously during anaphylaxis. So we did a bunch of research and found that the guidelines, both nationally, internationally, and by the World Allergy Organization, recommend giving epinephrine through an EpiPen to treat anaphylaxis. So it needs to be administered very quickly, and how quickly this epinephrine is administered can affect your patient outcomes. So through a lot of research, it's been found that the EpiPens are the safest route to administer epinephrine during these situations. For one thing, they are pre-filled, so there is no dosing, there's no drawing up the medication or pushing only a certain amount. You're only giving what is in your pre-filled syringe, so it takes away all of the risks associated with dosing. Administering it is much easier as well because you're just giving that fixed dose that's in there, and to give it, you're just going to swing the dose into the patient's thigh and hold it there for a few seconds, and the administration is done. And to add to that, there were several studies that suggested that there's a lot of radiologists that don't have a lot of critical care experience, and they don't get to see these patients that frequently, so they just don't feel prepared to care for them. And so when the radiologist, who is your only physician that is there, doesn't feel super confident in caring for these patients, it just exacerbates the entire situation when the staff is kind of feeling the same way and they don't really know what to do, and can make for a very stressful situation. And then there's a study listed below by Mash et al. Who did some research on radiology residents who found that there was a lot of fear and uncertainty with giving epinephrine, especially intravenously, and they had a 63% error rate when administering it that way. So the research that we did drastically drove the protocol change that we made, which was one of the first changes associated with this project. So for the theoretical framework, we used Dorothy Johnson, who was known for her work surrounding the behavioral system model. And she started this model back in 1968, and it focused largely around the effective behavioral functioning of patients to prevent further illness and the effect that it has on their overall health. And so it really stressed the significance of research-based knowledge regarding nursing care. And so we decided for this project to really base it on research and, see what recommendations were out there. And the other aspect that we brought into this was caring for the patient as an entire patient. So thinking about them not just physically and medically, but also emotionally. So when experiencing anaphylaxis, these patients are extremely scared. They feel like they can't breathe. Once you give the epinephrine, their heart rate generally increases. So they're feeling their heart fluttering, and their blood pressure can drop, which is going to make them feel lightheaded. And it's a very scary experience for patients to go through. So it's important for us as healthcare providers to acknowledge this and treat the person as a whole, and to not just focus on the medical treatment plan, but also think about how they're feeling right now and what's going through their mind, and how to treat them as a whole person and, comfort them during this time and help explain to them what's happening so that they have a better understanding of what exactly is going on. And then there's also another part of her research focused on the knowledge base that nurses needed in order to deliver good nursing care. And so this also kind of affected our project because we wanted, part of our staff here is nursing, but it's not all nursing. But we want our staff to have the knowledge that they need and that basis of knowledge to provide the best care that they can, because it is so important. So for our methods and design, so the facility that I work at is in the southeast region of the United States, and we'll be using all of the staff from this facility that are clinically based, and they're going to be involved in an educational-based intervention and testing to determine the competency in the care of anaphylaxis patients. So it's going to be a quantitative and exploratory design. There was an anonymous pretest given in the very beginning, and then there was an educational and skills-based session that was given to everyone, and this was followed by another anonymous test that was going to be the post-test. So the pre and post tests were then compared to determine if there was a statistical significant improvement in the test scores after everyone received the training. So during the educational training, there were several standardized interventions to make sure that everyone got the same education. So to do this, we gave a PowerPoint presentation, which included all of the pertinent information on how to care for these patients to just kind of standardize the education that was given. And it also consisted of a hands-on skills session to give everyone the opportunity to kind of practice doing what we were talking about as far as administering oxygen and giving an EpiPen, and getting vital signs and assessing patients. And then we also did education on the anaphylaxis boxes that were created. So another part of this project was creating anaphylaxis boxes, which were used for these specific patients. So they were designed just for anaphylaxis patients so that when these situations occurred, everyone wasn't running around looking for supplies and medications. It was all in one given box. So part of the education was showing staff where these boxes are now going to be kept and everything that was in them so that they were aware of them and comfortable with them if they needed to be used. So to kind of piggyback off what we just talked about, the pre-tests were given, the educational session was given, and then the post-tests, both tests were designed to be identical so that there was no biases or inconsistencies with the complexity of the questions given on the tests. The data collection process was stopped after 30 participants completed both the pre and post tests that all met the inclusion criteria. And in order to ensure the reliability, we used a test-retest design, which again was why we used the same pre and post test. And then the validity was based on the content validity. So we did a really rigorous search of all of the anaphylaxis information that we could find, and then compiled the test based off of this content. And at the bottom here, you can see just a little diagram to kind of explain the whole situation. And so what is anaphylaxis, signs and symptoms, administering oxygen and nebulizers, vital signs, first interventions, and then EpiPen administration. So these were the slides that were in the PowerPoint, as well as some of the hands-on aspects that just kind of touched on everything that we went over during our educational sessions. And our sample. So we used only clinical staff at this diagnostic imaging center, which totaled 30 participants. So there was 10 technology technicians from MRI, and then there was 6 CT techs. We had 7 x-ray techs, 2 nurses, and then 5 technology assistants. And you can kind of see a breakdown there of the age ranges. Everybody was pretty much in between the age of 28 and around 58 or 60. And it gives a breakdown of specifically of all the demographics. Mostly was Caucasian females. There was a few Caucasian males, 1 African American female. And then the inclusion criteria was based off of all clinical based staff. And it did not matter how long the employee had been employed there. That wasn't looked at when looking at the inclusion criteria. And the only exclusion criteria were people that weren't clinically based. So essentially like the front office staff who did not directly care for patients. They were not involved in the study. So for our data analysis, we used the SPSS system, which was utilized through Maryville University. And we used a Wilcoxon signed ranks test. And we used this instead of like a t-test, specifically because most of our data for the post-test were 10 out of 10s. And to kind of standardize the results that we had, if we had used a t-test, it would have looked like all of our data was skewed. So that is why we had to use the Wilcoxon sign ranks test. And when we used this statistical analysis, we found that our results were very statistically significant. So you want your p-value to be less than 0.05, and ours were 0.000, which is great, and showed that our results were very significant. So our N is our sample size, which was 30, and then you can see the mean values. So for the pretest was 6.97, so that's an average of all of your results, which is much lower than your average of your post-test, which was 9.8. And then you can see your standard deviation is higher for the pretest than it was the post-test, which just means that there was a lot more variability in the results, where the results were all much closer together for the post-test. So you can see the minimum was 8, maximum was 10, And in the pretest, your minimum was 2, while your maximum was 10. So for our results, there's a graph down here at the bottom that kind of gives you a visual of that. So your pretest is going to be in the blue, and you can see how much variability there is in those results and how much lower the scores were versus the post-test, which was much more standardized. Most of the results were 10s, if not just slightly below. So you can see how much of an improvement there was between the two tests that were given. So some limitations of this study. One limitation was that we had to use the same test for the pre and post tests. So while we initially did this to reduce the variability of the two tests and the potential for one test to be harder than the other or have information that the other did not have, it still impacts your results. So if you give the same test 2 times, people are going to remember some of that information, which unfortunately for this project just couldn't have been avoided. Another limitation is that the results may not be sustainable. So we only did a pre-test and a post-test, which was done immediately after our educational-based session. And so we didn't test how these participants would have done a week after the session had ended, or a month later, or 3 months, or 6 months later, to see if this education was sustainable or not. And there were several factors that could limit the generalizability of this study. So the study took place in a very specialized facility, being an outpatient imaging center. It may not necessarily be applicable to every other specialty in the healthcare field. We also specifically looked at anaphylaxis, which also really specializes the study. And again, it just makes it less applicable to everyone else that may wish to use the study. So one unexpected outcome was the number of participants. So we had the sample size that was required, but unfortunately we didn't have as many participants as we thought we were going to, and this was largely because of COVID and all of the complications that arose with that. We had expected to have many more, but because of scheduling conflicts and several other variables, we just couldn't get all of the staff in there to use them for the study. But there was several strengths. So while the sample size was not as large as we thought it was still more than what we needed for the sample size requirement. So while it wasn't as much as we wanted, it was still plenty adequate. And another strength was how strong our statistical significance was for our results. It just really demonstrated how strong these results were. And while it may not be completely applicable in a very focused sense to the entire healthcare field, if you look at it in a broad spectrum outlook, the entire project was just based on whether or not you can educate staff on a given topic and see if it helps their competency in caring for these patients, which in some ways is applicable to any healthcare field. So hopefully it can be applied to many other settings. And then the implication for nursing practice. So it demonstrates the value of educational interventions where there's a concern for competency for any healthcare staff. So throughout healthcare, regardless of what type of field you work in, there's always concerns for competencies, and medicine is constantly evolving. So there's always new things to learn and new weaknesses in our care. And so the project just really demonstrates how important education is and continuing education and how important that is for our healthcare staff and how much it can improve our competency as a whole in caring for our patients. So implications for future research. Future research could use this project as a starting point for conducting similar studies. So you could try it in different facilities or different specialties and see if you had similar results. And you can also do different approaches to the type of education that you're giving. So we used a PowerPoint, we used a live speaker that was presenting the information, and then we did skills sessions that were all hands-on to allow everyone to kind of interact with the supplies that we were given. So we kind of had several different educational interventions, but someone could look at how effective it was to use one versus the other, or even different educational interventions. And as discussed earlier, you could also test the efficacy of this intervention long term. So you could look at it 3 months from now or 6 months from now and see how sustainable the education will be. And conclusions. So the project that I did largely impacted the staff that I work with and their care and comforting patients that are experiencing anaphylaxis. So I had several coworkers say just how much more comfortable they felt caring for these patients after having this intervention. And it also started a tradition at the facility where they will now be doing anaphylaxis training biannually. And it won't just be at the current site, but it will also be at every site that our organization has. And personally, the entire DNP program here has really shaped me as a nurse practitioner, and it has inspired me to want to do more research projects in the future. This was my first big research project, and it really has inspired me to do more quality improvement projects and more research projects in the future, because I really enjoyed it. Does anyone have any questions about anything? And here are a list of all of my references that were used in this PowerPoint. Thanks, everyone.